identify the stages of sepsis, discuss treatment options, and review some of the recent trends in sepsis. So what is sepsis? It's a systemic response caused by microbial invasion of normally sterile parts of the body. It can be unpredictable and it can progress rapidly. Multi-organ failure can occur. And then this is a severe medical condition that can lead to death. And this image here on this slide is a picture of E. coli as seen under the microscope. And infection with E. coli, it can be a common cause of bacterial sepsis. So what kind of infections are linked to sepsis? We have several pictures here. So bacterial infections cause most cases of sepsis, as I previously mentioned. So for the lungs, pneumonia is a common cause of sepsis. And then you have UTIs, especially for our long-term care facility residents. These are two of the common causes of sepsis in that population. And then your skin, if there are any burns or anyone has like a cut or a wound, they can become septic from that. And then our GI tract, it could be appendicitis or it could be ulcers that cause sepsis. And sepsis can also be a result of other infections, including viral infections such as COVID-19 or flu or any fungal infections. And the most frequently identified pathogens that cause infections are like your Staph aureus, E. coli, and some types of streptococcus. And many nursing home residents who require hospitalization for COVID-19, they may have signs and symptoms that meet the definition of sepsis. This is just a picture of what it would look like with the bacterial infection in the bloodstream. So as you can see here, it's going to affect the vessels. They may be leaky, and your body, of course, is going to have an inflammatory response. And so the different organs that can be affected are your lungs, heart, liver, and your kidneys. So this infographic here is from the CDC, from their initiative, Get Ahead of Sepsis. And as you can see here, each year, about 1.7 million adults in America develop sepsis. At least 350,000 of those die during their hospitalization or their discharge to hospice. So let's take a look at the different stages of sepsis. So the first stage, or at least the initial phase of sepsis, is what they call SIRS, or systemic inflammatory response syndrome. And as you see here, the individual will have a temperature that may be 100.4, greater than 100.4, or less than 96.8 degrees Fahrenheit. They will have an increased heart rate. Their respiratory rate will be greater than 20. The PaCO2 will be less than 32. And then their WBCs may be elevated or decreased, or they'll have a greater percentage of bands. And so with the bands, as you know, those are immature neutrophils. And we know that neutrophils are a type of WBC or white blood cell that plays a crucial role in the body's immune system. So it acts as the first line of defense against infections and injuries. And it's the most abundant type of white blood cell in our body. And it makes up about 50 to 70% of all white blood cells. So we know if that's increased and those cells are, trying to fight off this infection that's in the body. So that's an indicator that there's something going on. So stage 1 is sepsis. So you have to have 2 of the symptoms of the SIRS plus a confirmed or suspected infection. So this means that the person probably has sepsis. And stage 2 is severe sepsis. So it's sepsis plus signs of organ dysfunction. So some of those major organs will start not functioning properly. And then stage 3, septic shock. You have severe sepsis with persistent signs of organ damage. Their blood pressure will be dropping less than 90, and then their lactate levels will be greater than 4 millimoles per liter. So those are definite signs that this person is in septic shock. So what is the importance of the SIRS criteria? The SIRS criteria. The SIRS criteria are commonly used in the emergency department settings as a screening tool to identify septic patients. However, it can also be used in the long-term care setting to identify if your patient may be septic. So there's not, while it's not specific to sepsis, the SIRS criteria is accompanied by signs of infection, which we noted on the previous slide and here in this slide. And this can alert you to the possibility of sepsis. So there are some guidelines about using the SIRS criteria, and they have really shifted the focus to organ dysfunction and not necessarily focusing on the SIRS. But the SIRS criteria can still be used to assess the severity of a patient's condition and guide treatment, or whether this patient, needs to be sent out to the hospital. So CMS has not changed their stance on using SIRS as a criteria to assess sepsis. So just keep that in mind. But it is a great tool to use. So SIRS is a stage in the progression of sepsis. It's potentially leading to severe sepsis. And identifying SIRS triggers the need for early and aggressive treatment of sepsis, including IV fluids, antibiotics, and source control. So early intervention and identification is definitely important. To get ahead of this person developing severe sepsis. So in stage 1 sepsis, our body immune system overreacts to that infection. This stage is characterized by the body's overreaction, leading to widespread inflammatory response. And then SIRS can manifest itself as early as stated by fever, increased heart rate, rapid breathing, and also altered mental status. In stage 2, severe sepsis, this stage occurs when sepsis progresses and organ dysfunction becomes apparent. So like difficulty breathing, decreased urine output, and again, confusion are part of the stage 2. And then in stage 3, this is when the patient is in septic shock. This is the most severe stage. The patient's organs have begun to fail. They are hypotensive. And in septic shock, the body may be unable to maintain adequate blood flow to vital organs, leading to severe complications. And ultimately, it may lead to death. And so early intervention is what we want to prevent, this last stage where the patient goes into septic shock. So we're going to look at now some early assessments. These are some risk factors for individuals who may be at high risk for developing sepsis. So as you see here, first on the list is anyone who's 65 years or older. Of course, we know they're immunocompromised for the most part just because of age and maybe some other comorbidities that they may be dealing with. And so any kind of infection can trigger sepsis. We also know that people with weakened immune systems, those who are receiving cancer treatment, have a weakened immune system. People who have diabetes or HIV/AIDS also have a weakened immune system. And then people with recent severe illness or hospitalization, including due to severe COVID-19, are also at risk. And people who survived sepsis, and then children younger than 1. And you may say, well, why would people who survive sepsis be a risk factor? Well, we have to remember that if they had sepsis, that they had a lot of stress on the body. A lot of their organs may have become damaged because of sepsis. So they're at higher risk because they may be also immunocompromised. So it's important to monitor those patients as well, those who have previously had sepsis. And then, of course, severe illnesses that requires hospitalization can also lead to problems with a person's immune system, raising their risk factor of sepsis. So do you have a sepsis program? That's something most healthcare facilities should have in place. Because remember, early intervention is important so we can prevent that patient from going into septic shock, because things happen rapidly if the person has sepsis. So you want to identify a leader. So an appointed person needs to be identified, or a co-leader to drive the program's implementation and ensure accountability. You want to make sure, and this is just an additional thing. Some facilities may not be able to do this, but the program outcome compensation may be tying compensation to the program outcomes. You could consider tying a portion of compensation to the success of the sepsis, program to motivate staff. And then the needs analysis. You want to evaluate existing sepsis screening tools. Do you have those in place? What are the treatment guidelines? And any data reporting processes to identify areas needing improvement. You want to make sure you have relevant data, gather information on regulatory compliance, use of screening tools, and other order sets to pinpoint specific areas of focus. And then, of course, you want to include your multidisciplinary team, having a collaboration with them. You want to engage your stakeholders and involve various departments and professionals, because that's key in having a successful sepsis program. You want to include your infection control or infection preventionists, nursing, pharmacy, even your physical therapy. If you have physical therapy or rehab program in your facility, you want to include those individuals as well, because they play a vital role in caring for these residents as well. And then provide ongoing education. That's important. And then implement structures and processes. You want to try to develop a sepsis recognition tool, a tool that facilitates rapid identification of sepsis and integrating that into your existing workflows. And then have an established rapid response system. You want to have a team that's with possible critical care training, if possible, to respond quickly to a suspected sepsis case. And then tracking, reporting, and continuous improvement. You want to track your data, monitor those key performance indicators or KPIs related to sepsis screening, treatment, and outcomes. And then establish a reporting mechanism, and then conduct ongoing audits and evaluations of your program to make sure it's doing the purpose and meeting those goals that you have in place. So some additional questions to think about is, are your staff educated on the importance of sepsis recognition? Do you know which residents have the most risk for sepsis in your facility? And this is where your tracking system can help you. And are you closely monitoring residents who were discharged from a hospital with an infection? And do you educate your short-term residents on discharge on the importance of identifying sepsis? Because they need to be aware of that post-discharge. And then I know this says a hospital sepsis program, but this is kind of what you want your sepsis program to look like. You need the commitment from leadership, ensuring that they dedicate the appropriate individuals for this program financially, and the technology that may be needed to monitor this program. And then accountability. That's where having a leader in place, someone that's going to oversee this program, or a co-leader. And then your multidisciplinary expertise, having an action plan in place, and then tracking, reporting, and education. So this is what a fully implemented program should look like. So then let's look at the assessment for sepsis. So you always want to, get that patient history, especially a new admission, to figure out what's going on or what could have gone on with this patient previously. Because like I mentioned earlier, they could be, they could have had sepsis in the past. So that would key you in on, okay, we need to kind of monitor this patient to make sure, they don't develop sepsis again. You can inquire about recent fevers or other symptoms that might suggest infections. And then some residents may not be able to communicate symptoms of infection due to either dementia or some cognitive disability. So, that's where you're looking and assessing that patient from head to toe to make sure you don't identify anything. And then looking at those vital signs, what's their temperature, blood pressure, because those are all indicators of sepsis. What about their mental status? And what about a patient newly admitted that you don't know? For your residents that are current residents of your facilities, you may be able to, identify, oh, this patient is normally not confused. And then that would key you in. But anybody new to your facility, you don't know their status. So that's important to do your assessments to ensure that this person is not coming from wherever or whatever facility they're arriving from and may be exhibiting signs of sepsis. And then checking the skin assessment. Check for signs of infections, rashes, cuts, or burns. And then checking their oral cavity for any abnormalities, especially abscesses, because abscesses can turn into sepsis. And then their urine output. What's their urine output? Because that can indicate poor perfusion and organ dysfunction. And then if you suspect a respiratory infection, do a chest x-ray or some other imaging. And then there's the Q-SOFA criteria, and we'll talk about that a little later. And then source identification. Carefully assess for all possible sources of infections. And then just like I mentioned earlier, just knowing who is more susceptible and at higher risk for developing sepsis. And I can't stress enough, early identification is so important. So let's utilize Lucas. How many of you have heard of Lucas? So this is a mnemonic that's used in medicine to help remember potential sources of infection. and to help in the diagnostic process of sepsis. It stands for lung, urine, central nervous system, cardiac, abdomen, skin, spine, and septic arthritis. And here you will see the different conditions that you want to identify when utilizing Lucas. So for lungs, there may be, they may have pneumonia or a respiratory infection, and urine, UTIs, for the CNS system, meningitis or encephalitis, endocarditis for the cardiac, or abscesses, cellulitis, and then if they have an IV or any type of line, a PICC line, assess those and ensure that they're not inflamed or, looking like they're infected. So Q-SOFA. So Q-SOFA is sequential or quick sequential organ failure assessment. And it's a bedside prompt that may identify patients with suspected infection who are at greater risk for poor outcomes. It uses 3 criteria, assigning 1 point for low blood pressure, high respiratory rate, or altered mental status. And so the scores range from 0 for normal or greater than or equal to 2 would suggest a high risk of poor outcomes in patients with suspected infection. So often long-term care staff are kind of at a disadvantage of being able to discern sepsis, like I mentioned earlier, especially in those new admissions, because you don't know that patient. But utilizing your facility sepsis program and other tools that are at your disposal will help you quickly identify if a resident is septic. So next we're going to look at the signs and symptoms of sepsis. So this little infographic here spells out in a mnemonic sepsis. So to help you immediately identify, look at the S in sepsis. Are they shivering, which could mean they have a fever, or they're cold, which means that, their blood pressure possibly has dropped. Then the E for extreme. Are they having any pain or discomfort? And P, paleness. Are they discolored, clammy, or sweaty skin? And then S for sleepy. Are they confused or are they disoriented? And then the I, if they're stating that I feel like I might die, or, I feel weird or something to that effect. And then S for shortness of breath. Are they having difficulty with breathing? And now we're going to look at some sepsis impersonators. So there are different conditions that may mimic sepsis. And so they're listed here, possibly a pulmonary embolus, adrenal insufficiency, DKA, pancreatitis, anaphylaxis, a bowel obstruction, hypovolemia, or colitis. And these are common causes of some misdiagnosis in emergency departments. All of these clinical conditions do produce symptoms and signs that meet the SIRS criteria. So some of these conditions, the person may develop fever, they may have elevated WBCs, they may have difficulty breathing, decreased distal perfusion or low urine output, they may become confused, or they may have organ dysfunction. And so all of these conditions have a commonality, and they trigger a systemic reaction that looks just like sepsis. So they can, you may think, oh, this person has sepsis, but that's what we continue to assess to see what's going on with this patient. And again, time is of the essence to treat these conditions due to increased chances of mortality, because these are life-threatening conditions as well that need to be treated immediately. So next we're going to look at sepsis interventions. What can we do to help intervene? So the 1 hour sepsis bundle, it's a series of interventions to help with rapid diagnosis and treatment of sepsis. It's ideally done within the first hour of recognizing that a person may be septic. And the goal is to initiate treatment as quickly as possible to improve patient outcomes and reduce mortality, because we know things will happen quickly. So you want to ensure we're, on top of things and getting those patients treated immediately. And so measuring the lactate levels, you want to make sure the person tissues are appropriately perfused. And then before administering antibiotics, and you'll hear me talk about this again within the presentation, you want to make sure you get the blood cultures prior to administering antibiotics so you can identify the organism that may be causing this patient to be septic. And then prompt administration of antibiotics is crucial into controlling this infection. And then fluid resuscitation is important in restoring their hemodynamic balance in the body, especially in those patients who are hypotensive or have high lactate levels. And so if hypotension persists after they've been given fluids, then the clinician may have to provide vasopressors to help maintain the blood pressure. So just remember, just like a heart attack, stroke, or any trauma, the speed and treatment administered in the initial hours can make a difference. And you'll hear me keep stressing that, the quickness and the speed of implementing any interventions is imperative for these individuals. And so this is just an infographic of what the 1 hour bundle looks like. So it just shows here, once you've recognized that this patient may be septic, you want to go ahead and measure those lactate levels. And then it says here that you want to remeasure if the initial lactate levels are greater than 2. You want to get those blood cultures before administering the antibiotics. Administer broad spectrum antibiotics. Begin rapid administration of crystalloid for hypotension or high lactate levels. And then applying those vasopressors if they're hypertensive and, it's not being resolved with the fluids. So CDC has this prevention tool called Get Ahead of Sepsis, which I mentioned a little earlier. So it's for healthcare providers, families and caregivers, as well as patients. And the goal of the Get Ahead Sepsis educational effort seeks to optimize healthcare quality and patient safety by raising awareness and knowledge and motivating behavior change related to the prevention of infections that can lead to sepsis. And then early recognition of an appropriate treatment for sepsis among consumers and healthcare provider target audience. And then additional tools and resources is this Surviving Sepsis campaign. And this is an international campaign. It's a joint initiative with the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. And it's led by a multidisciplinary international experts, and they're committed to reducing mortality and morbidity from sepsis and septic shock. Excuse me. And sepsis is a leading cause of death worldwide. So this is a good tool and resource to look at. Once you're trying to implement your sepsis program, if you don't have one in place. Okay, so sepsis education. Who should be educated? Our hospitals, our clinicians, our intensivists and ED physicians, our nurses, other healthcare professionals, the general public, our patients with sepsis. Because remember, I said patients with sepsis are more, they're higher risk for developing sepsis again. Our school nurses, because we do have, students who can become septic, because of some injury, and they may start exhibiting signs and symptoms while they're at school. Youth coaches, we know children get injured while they're playing sports. So youth coaches need to be aware of the signs and symptoms of sepsis. And then our emergency responders, they're usually the first ones to respond. So if they can identify, when they're going out to pick up a patient, be able to identify whether this person has an infection and whether they're septic. And then pharmacists. Pharmacists play a role because we know that antibiotics need to be administered to these individuals. So they need to be aware of sepsis as well and its management so they can provide appropriate medication guidance to the clinicians. So everyone needs to be aware about sepsis. So always remember time. We need to make sure we're acting quickly. And this little infographic here is something, you can have posted somewhere to remember, the temperature. Is it an infection? Are they having mental decline? And are they extremely ill? So just identifying those things early. Remember, time is of the essence. So you want to ensure you're treating those patients immediately. So we're going to look at now some treatments measures for sepsis. So again, rapid antibiotic administration. Collect blood cultures before administering antibiotics. Fluid resuscitation, vasotherapy, vasopressor therapy. Providing those fluids rapidly to restore the stability of the patient. And then source control, ensuring that the patients that we're identifying those issues with that patient. And then utilizing vasopressors. And then back to source control, you want to make sure you're identifying those issues that may be causing the infection because, they may have, like I mentioned earlier, a draining abscess, or they may have an infected device that may need to be removed because this could be a post-surgical patient that may have a device that may need to be removed. And then prevent stress ulcers in the GI tract, particularly for those patients with risk factors. And then preventing those PEs or thromboembolisms. You want to prevent those using some type of anticoagulant. And then monitoring. It may include mechanical ventilation. You may need to monitor the vitals, including their blood pressures and the heart rate. And the other supportive measures would include like mechanical ventilation and renal replacement therapy or other resuscitative measures that may be needed to help this patient. So there are antibiotics that can be used to help treat these patients who are septic. So all of these antibiotics listed here are broad spectrum antibiotics. So the parapicillin, tazobactam, TAM. It's particularly active against gram-negative bacteria. The cefepime is active against gram-positive and gram-negative pathogens. Then the ceftazidime is effective against many gram-negative bacteria and is sometimes used in sepsis treatment, especially those who may be infected with Pseudomonas aeruginosa, if that's suspected. And then meropenem is also commonly used for sepsis, as well as imipenem. So the Agency for Healthcare Research and Quality has 4 moments of antibiotic decision-making tools, a tool for healthcare providers. And so this tool helps the provider identify when they need to provide antibiotics, or what decision they need to make. Should they use antibiotics, or or shouldn't they? So the first moment, it occurs at the initiation of antibiotic therapy. And so they need to consider or ask themselves, does my patient have an infection that requires antibiotics? So in moment 2 occurs when the decision is made to start antibiotics. And they need to think, have I ordered appropriate cultures before starting antibiotics? And what empiric therapy should I initiate? Moment 3 occurs every day of the antibiotic therapy. So can I stop the antibiotics? Can I narrow therapy? Can I change from IV to oral therapy? And then moment 4 occurs when the infectious process is clear and the patient responds to therapy. And then they need to ask themselves, what duration of the antibiotic therapy is needed for my patient's diagnosis? So this is a good tool for clinicians to utilize. So now we're going to look at just a couple recent trends with sepsis. So this first article here, well, it's a statistical brief. It's from the Agency for Healthcare Research and Quality, and then the HCUP, or Healthcare Cost and Utilization Project. So it just presents statistics on inpatient stays related to sepsis using 2019 and 2021 state inpatient databases for 47 states. And what I want you to note here is that they were looking at those hospitals in urban areas and rural areas. And so in 2019 and 2021, urban hospitals had a higher percentage of stays related to sepsis than rural hospitals. And that may be because the patients were very ill and had to be transported to an urban hospital versus receiving their care in a rural hospital. So this statistical brief does exclude data for rehabilitation and long-term acute care facilities, but I provide the references at the end of this presentation. So if you want to take a look at this more in depth, you can. So this infographic here just looks at state-specific population rates of sepsis related to inpatient stays overall and involving COVID-19 in 2021. And so the state-specific rates of sepsis related to inpatient stays and the subset of sepsis-related inpatient stays involving diagnosis of COVID-19 was per 100,000 population in 2021. So just note that the population rate of sepsis-related inpatient stays was based on any listed diagnosis of sepsis. So just of note that some of the southern states, Mississippi, Tennessee, Kentucky, Florida, and West Virginia, 5 of the states in the South had the highest population rates, ranging from 881 to 1,089 respectively. And as you can see there, South Carolina, we're We're almost one of the higher states, but we don't quite meet the other states in the South. And then Alabama did not have any data available. So the burden of sepsis in the U.S., this is a report that goes to Congress. And this report offers a comprehensive assessment of hospital care for sepsis in the United States. So it looks at morbidity and in-hospital mortality-related sepsis, disparity in sepsis outcomes, and the hospital burden of sepsis, and the state variation in hospital encounters. So tracking sepsis incident, treatment, and outcome can be challenging due to the absence of a gold standard diagnostic protocol. So there's no gold standard of how you, identify sepsis. And so due to the increase in concern about sepsis-related hospital use and outcomes, the federal and state agencies, along with some non-governmental organizations, have invested in surveillance and quality improvement efforts to enhance the use of evidence-based practices in sepsis care and to monitor sepsis morbidity and mortality over time. So this report provides that information. So this next slide is from CDC, and it shows that for a typical year, 1 in 3 people who dies in a hospital had sepsis during their hospitalization. So that's a lot of people, 1 in 3. But then it goes on to say, but half of U.S. hospitals provide dedicated time for sepsis program leaders. And that was from a 2022 survey of 5,000 hospitals. So they are dedicating their time to their sepsis programs. And as you see here on the right, the program data, 73% of hospitals have a sepsis committee. 55% of hospitals provide dedicated time for sepsis program leaders. And then 55% of sepsis committees involve antibiotic stewardship programs, which is good because antibiotic stewardship is definitely important when looking at sepsis because you're administering, these antibiotics. So this slide here is another statistical brief, just the overview and outcomes of inpatient stays involving sepsis. And just to note that between 2016 and 2019, the number of all sepsis-related inpatient stays in the U.S. increased by 20.1% to 2.1 million stays. So that's kind of a significant increase. So, facilities need to be aware and just in rapidly identifying sepsis cases in their facilities. And this is trends in inpatient stays and mortality rates involving patients with sepsis. As you can see here, at the top there, the line with the circle through it, those are the number of all sepsis-related inpatient stays with and without COVID. So it's depicting both. And the dotted line with the circle shows the number of sepsis-related inpatient stays without COVID. So that number is a little lower. So, does that lead us to believe that, we had more patients that were septic due to COVID, possibly? And then this is another trend report of the number of inpatient stays and hospital mortality rate for stays involving sepsis by patient population. And this just looks at the number with and without COVID again. And then the in-hospital mortality rate for sepsis stays with and without COVID, and those stays with COVID are denoted in the blue. And so this looks at the hospital costs related to sepsis. And it's just an aggregate of the cost for hospital stays. So over half of the aggregate hospital costs for sepsis stays in 2020 and 2021 were associated with stays that were expected to be billed to Medicare. So about 56.3% and 53.9%. And then just to note that in 2020, the largest proportion of aggregate hospital costs for maternal sepsis stays was 60.1%. And it's just talking about how they were billed either through Medicare or Medicaid or private insurance. So this looks at the distribution of aggregate hospital cost. So as we can see here, again, the percentage of sepsis stays resulting in transfers to skilled nursing and intermediate care or another facility, it actually decreased from an average of 32.6% in 2016 to 2019 to 27.7% in 2020 and 26.7% in 2021. So this again is looking at the different payers for sepsis. And just of note, other dispositions of people leaving against medical advice and patients discharged alive or even missing patients or even invalid data, the distribution of the number of inpatient stays for sepsis by discharge disposition was based on stays in which sepsis was the reason for the stay or the principal diagnosis. And I think I moved a little ahead of myself, but this is showing what I just mentioned about the transfers to a SNF or ICF, those who may have died in the hospital, home health care. So it's just looking at the number of inpatient stays by population. So some of future approaches and treatments of sepsis. This image here is of some MUSC researchers who discovered a novel biomarker for sepsis severity. So again, there is no single definitive gold standard test for sepsis. Blood cultures are a gold standard for identifying the bloodstream infections. They don't definitively diagnose sepsis because sepsis can be is a clinical diagnosis based on the infection and organ dysfunction. So the MUSC researchers, like I mentioned, they identified this biomarker that could change the way sepsis is approached and treated. So of course, there are still many hurdles that must be cleared before those biomarkers are used in the clinic or in a healthcare setting, but certain factors could speed that progress. So hopefully, that's something that will occur soon to help identify early on those individuals with sepsis. And then this is a recent study from 2023, and Dr. Lee from MUSC, who was pictured in the previous article, was the lead author for this research. And so this is from the Frontiers Immunology resource. So the researchers report that the severity of sepsis could be predicted by the contents of membranous structures known as extracellular vesicles or EVs. And these are shed by cells in the bloodstream. So based on sepsis severity, treatment protocols could then be tailored to the individual patients and reduce the mortality rate and organ failure with severe sepsis. And so this EV technology, it already exists. It's a simple blood test known as a liquid biopsy. And it could be used to collect and analyze EVs and the changes that occur in their contents in a patient with sepsis. So the MUSC research team, they hope that by studying the proteins and RNA found in EVs, that sepsis severity can be predicted, allowing treatment to be tailored to the individual patient. So that's hopefully coming soon. We're already, they did this in 2023. So this is 2025. So hopefully they're close to identifying, how they can use this this test to identify those patients with sepsis. So let's go back to the question asked in the presentation title. Can it be sepsis? Maybe or maybe not. So yes, it can. It's a high probability that it is sepsis. You need to make sure you're acting fast, and then don't forget the impersonators. Remember that time is of the essence when the patient is suspected of having sepsis. Healthcare providers should utilize your facility sepsis program and other tools that you have in your arsenal to provide rapid assessment of the patient. And then just remember, infection prevention is the best way to reduce the risk of infections and sepsis. Make sure that your facility follows CDC core infection prevention and control practices for safe healthcare delivery in all settings, and follow your facility's policies. So just remember those things. We want to act quickly when we identify or suspect sepsis. And so this is just a flyer of our healthcare associated infections unit, our contact information, and some of the services that we provide. I'm just going to throw the little plug out there. If you need help with anything related to healthcare associated infections, we are here to help. We're with the Department of Public Health. We're not regulatory, and we can come out and assist any facility, with identifying any infection infection and prevention control issues. Or if you have an ongoing issue, and you just don't know what to do, reach out to us. There's no cost for us coming out to work with you, and we are available. We're here for you. So please reach out to us if you need to. And these are the references that I mentioned, and that is the end of my presentation.
Thank you, Alison. This was excellent. And the focus on the importance for early intervention and treatment is keys. And we greatly appreciate it. If anyone has any questions, please feel free. We just have a couple minutes left to ask the question or put it in the chat. And I wanted to let you know that the recording of this will be on YouTube under Constellation Quality Health, and that will be available within the week. And also, if you would please complete the survey at the end, and if you have any suggestions for topics for our quality leader sessions, then we would appreciate that. And the next quality leader session will be in June. It's the third Thursday of the month on June 19th. And it's going to be Tori Anderson, and she's speaking on dementia care and the latest treatments. And thank you, everybody, for joining us. And we look forward to seeing you again in June. And thank you very much, Alison. You were wonderful.
Thank you.
Thank you, everybody. Take care.